Hi, everyone. I'm Drew Armstrong, Bloomberg's senior editor for healthcare. Welcome to The Future of Healthcare, Caring for Polychronic Populations. Today, we'll examine the issue of people living with polychronic conditions. Polychronic patients are those with 3 or more chronic diseases, and by some estimates, this population will triple in the coming years, from 30.8 million patients in 2015 to 83.4 million patients in 2030. So it's a very important issue for patients, for doctors, and for healthcare systems to understand and treat. We've been reminded of just how important during the COVID-19 pandemic this is, as people with underlying medical issues are particularly vulnerable. Before we begin the program, a few housekeeping notes. If you're having trouble with audio or video quality, please refresh your browser. Also, please engage with us across social media using the hashtag #TheFutureOf. And at this time, we'll have a few remarks from Dr. Wyatt Decker, the CEO of Optum Health. Optum is the sponsor of today's briefing. And after we hear from Dr. Decker, my Bloomberg colleague, Michelle Cortez, will join us. Welcome, Dr. Decker, and thank you for being with us today.
Thank you for joining us. Hi, I'm Wyatt Decker, the CEO of Optum Health, which is part of Optum. Optum Health focuses on delivering healthcare to over 20 million Americans and helping over 98 million Americans on their healthcare journeys. I'm pleased to be with you for this Bloomberg Live session, which have been incredibly valuable opportunities to bring thought leaders together to discuss important issues and topics in healthcare today. As you all know, this year has been marked by profound disruption from the global pandemic. But the disruption that we've experienced and the challenges, and frankly, the humanitarian toll, have all been enormous, but not without some rather thin but important silver linings. And one of those is the opportunity to do things differently, to think about how we deliver healthcare, to make it more efficient and more people or consumer focused. As a practicing physician for most of my career, I think the key to getting healthcare right is really putting the person or patient at the center of everything that we do, creating a seamless experience that's delivered through a fully connected system, able to leverage new technology and data to its fullest potential. This will benefit all patients, but it's even more critical for a growing number of people managing multiple chronic conditions. Today, it's estimated that 6 in 10 Americans live with a chronic disease, and 4 in 10 live with multiple chronic conditions. People with chronic disease and behavioral conditions account for about 90% of the nation's $4 trillion annual healthcare spend. And these are individuals that will greatly benefit from a more personalized approach to healthcare. At Optum, we've created a holistic, person-centered model designed with these patients in mind. We leverage data and analytics to identify clinical opportunities and gaps in care. We equip providers with digital tools and insights to better coordinate and align care. And we help consumers navigate the health system and make smarter decisions that work for them, empowering both providers and patients. This is how to ensure people receive the best care in the right setting at the right time, affordably. And we mean everyone. The pandemic has revealed long-standing inequalities in our healthcare system. Data shows that African Americans and Latino are 5 times more likely to become sick from COVID-19, and the risk of an adverse outcome rises significantly for patients with chronic conditions. To save lives, reduce suffering, and advance health equity, as a society, we must invest in the health system to make the quality care accessible to underserved populations, not just during a pandemic, but every day and in every community. At Optum and United Health Group, we've been pleased to lean in on this effort. We are helping the hardest hit communities. Early on in the pandemic, data indicated that some communities were being hit harder than others. We immediately took action to address the hardest hit communities, launching testing initiatives targeting underserved populations as part of our Stop COVID initiative. This included efforts in Philadelphia, New Orleans, Los Angeles, and several other cities. In addition, United Health Group has committed over $100 million towards affordable housing during the pandemic, which brings the total commitment to affordable housing for those who are homeless or housing insecure to $550 million. These are just two small examples of how we are leaning in to help make a difference, both during the pandemic and before and over the long term. We know that this is going to take a lot of work, but we've seen what is possible when the private sector, government, and researchers come together and advance our understanding of human health to develop new solutions. With the right mix of expertise, determination, and compassion, we can create a fully connected health system that makes the health system work better for everyone. Thank you, and enjoy the event.
Thank you, Dr. Decker. Today we're going to get started by talking about this patient population that's dealing with multiple chronic conditions and the challenges that they face. Joining me today is a distinguished panel of physicians who have deep experience in this area. Please join me in welcoming Dr. Cynthia Boyd, a professor of medicine at Johns Hopkins University School of Medicine, an interim director in the Division of Geriatric Medicine and Gerontology. Dr. Michael Steinman, a professor of medicine in the Division of Geriatrics at the University of California in San Francisco and the San Francisco VA Medical Center. And Dr. Arlene Bierman, director of the Center for Evidence and Practice Improvement at the Agency for Healthcare Research and Quality, which is part of the Department of U.S. Health and Human Services. Thank you all for being with us. So let's get started with Dr. Boyd, who's going to give us an overview of this patient population, the kind of challenges that they deal with, and the ages and the numbers that we're talking about.
Thank you for having me here today. I'm really happy that you're focusing on this population. And I think one of the first things I would say is that I really like to think about this population as people who are living with multiple chronic conditions, recognizing that living with multiple chronic conditions is just part of who they are and what's important in their life, and that keeping them at the person at the center, I think, is really important as we try to ensure that the healthcare we provide is really what's best for them. So who is the population that we're talking about? So people with multiple chronic conditions in general are defined as having two or more health conditions. So they could be something like diabetes or arthritis, could be something like depression or anxiety at the same time that exist for over a longer period of time. So not an acute cold or something like that. And when we look at numbers in the U.S., it depends, of course, on what population you're looking at, the age of the group. But about 1/4 of people living in the U.S. have multiple chronic conditions. And even 1 in 15 children do. This is really an issue that increases across the lifespan as we get older. But it is really relevant at all ages as we think about designing the best care. Among older adults, about 2/3 to 3/4 are living with multiple chronic conditions. And one of the things that we see is that for many people, they may actually be living with 5, 6, 7, or 8 chronic conditions, and that this often goes along with a lot of healthcare and a lot of treatments and a lot of medications.
So, Dr. Steinman, let's talk about what people can expect when they are in this category. Is there a situation where people can know that they're at a tipping point, that, you know, a lot of people have something like high blood pressure or depression? Is it something that gradually builds over time, or can you know that you're at risk and that you need to be sort of taking additional steps to try to get yourself out of dealing with multiple chronic conditions that don't ever seem to resolve?
Yeah, it's something that often does build over time. In some cases, if you have a catastrophic event, for example, it can happen fairly suddenly. But for most people, this is the kind of thing that sneaks up on them. And Dr. Boyd mentioned that
many people with multiple chronic conditions, it's fairly few in number. For example, you might have high blood pressure and high cholesterol, and that might count as multiple chronic conditions. But for many, though not all people, but many people, that's fairly manageable. The number of medications are manageable. The kinds of things that one needs to do for lifestyle interventions are manageable. But as the number of conditions rises and people's personal situations might change, those two things can conspire to really make these things unmanageable. If you find yourself taking 10 or 12 or 15 medications or shuttling between 3 or 4 specialists who might be giving you somewhat contradictory information and find yourself confused, those are the kinds of people who I, as a geriatrician, especially worry about, because they're the people both at highest risk of bad health outcomes and also most at risk for having misadventures from their medical care, medications that are inappropriately prescribed, conflicting advice, confusion. And when people find themselves confused or uncertain or thinking, gosh, I'm taking so many medicines and seeing so many specialists, what is going on? That often is a sign that things are awry and we need to do something about it.
Dr. Bierman, can you walk us through what the current status is of caring for this patient population group? Your agency looks specifically at healthcare quality, and this, I would imagine, is a group that is particularly vulnerable when it comes to needing high quality care and perhaps has additional challenges in actually getting what they need.
Yeah, Michelle, you're absolutely right. So transforming or improving the care of multiple chronic conditions is a priority for AHRQ, or the Agency for Healthcare Research and Quality. And we know right now that our system doesn't often serve many of these people well. It could be fragmented care. They could see multiple specialists or sites and settings of care that are not communicating with each other. They might have complex regimens with high burden. But we know that there's a lot we can do to transform the health system. We have a health system that was built to take care of diseases, and we need to transform to one that takes care of the people living with those diseases, and often multiple, and design plans of care that they can follow and that can optimize their health, and that doesn't place a burden on them, and that's aligned with the context of their lives and their preferences. The other thing I just want to highlight real quickly is that you're absolutely right. We have an epidemic in this country. The prevalence of multiple chronic conditions is growing because many risk factors are the same for multiple different conditions, and we really do have to highlight preventing multiple chronic conditions as well as managing them better.
That's a great point. Maybe Dr. Boyd, you can follow up on that for us. Is there a time when people should be aware, and maybe when doctors should be reaching out to their patients to say, you are at a critical tipping point here, and there are steps that you should maybe take to try to avoid getting into a chronic condition, such as, once you have, more than 2 or 3, is there something that people can do preventatively, or is this pretty much an inexorable progression of disease?
That's a great question, and I think that there's several things that we do already know that can really help. For example, as we think about many of the chronic conditions that might be preventable, thinking about the role of physical activity, regular exercise, I think sometimes we tend to think that that's only beneficial for, say, preventing of heart attacks, but actually we know that physical activity, physical exercise is beneficial for us cognitively. It's actually good for our bones, like the strength of our bones. It helps prevent osteoporosis. So I think many of those things that really do take time and sort of changing our behaviors are effective. Other things are, stopping smoking, eating a healthy and balanced diet. These are all things that we do think actually will end up having impacts on both the likelihood of our getting multiple chronic conditions, but also how easy they are to treat or to manage. I do think that there are things that we also need to be doing as a society as well as healthcare systems that can that I think are really important when we think about prevention at a population level. For example, we know that not having access, for example, to healthy, nutritious food, not having a neighborhood where it's possible to walk safely, where the sidewalks are smooth, and maybe that there's handrails on steps or smooth ways of getting off of them. All of those things are things that I think we need to think as a society, how we're addressing not just what is within not just what an individual might be able to do, but how are they actually able to do that in their neighborhood with the resources and supports that are out there in their community and in our society.
I think that's a really important point, that it's not just the health system that's involved here, but also our communities and the way that everybody walks and lives in general and the support that they get. But I do want to look a little bit more deeper into the healthcare system itself. I'm wondering if, to what extent there is a specific physician that would be responsible for caring for these patients. I know in a lot of cases, if you're talking about somebody, say, with arthritis or perhaps somebody with Alzheimer's disease, they do have specialized physicians. But who is responsible for kind of coordinating all of the care? And is that well established? Dr. Steinman, maybe you can address that in the way that we are currently dealing with the healthcare system.
Sure. Well, the person who ultimately is, should be responsible and often is responsible for coordinating care is the primary care clinician, which should include a primary care physician, an internist, or a doctor, for example, or a nurse practitioner. Our system is not set up to make that work well. Primary care physicians of all those types are often overwhelmed, have little time. There's little coordination between them and the work of the specialists. And as a result, even though in theory and ideally, primary care physicians like myself should be playing that quarterback function, it can be very hard in practice. And so what we really need to be doing is both on an individual level, working with our physicians, our primary care physicians, to get them the information they need to help make these decisions and resolve these complex care dilemmas, but also create the structures that are actually going to allow primary care physicians to do the job that they're actually trained to do.
Dr. Bierman, this is exactly the area I know that you guys are looking into, raising the bar when it comes to quality of caring for these kind of patients. Can you tell us where we are in that effort? And, is there anything specific that you guys have underway in order to measure this and improve the quality of care across the country?
No, I think that the good news is that there's lots that we could do. I think the COVID pandemic has highlighted the burden of multiple chronic illness in the country and the challenge in getting optimal care. And, it's also highlighted how we need to invest in our public health system as well as our primary care system. And ideally, everybody should have a primary care team within a medical home that helps coordinate their care and supports them. But also we need to rethink how we deliver primary care, in that we need strong linkages between primary care and public health and community services, as well as to specialists and hospitals. And I think the other thing that gives me a lot of hope is that we're growing, just as we have clinical research, we really have the science of care to tell us how to best deliver and organize care in the context of a learning health system. So as we implement strategies to improve care, we can study them and test and learn what works best for which populations, but also learn how to scale and spread effective models of care across the country. If we have time later, I could give you a couple of examples of what ARC is doing in this space.
That sounds great, but Dr. Bierman, you did bring up the whole issue of COVID-19 and coronavirus. So maybe, Dr. Steinman, you can tell us how that is affecting your current practice right now, and in terms of how well patients who need to see their doctors maybe quite frequently now all of a sudden have less access because people haven't been going as frequently to their doctors as they were in the past because of concerns about coronavirus. How is that transition happening?
It's a great question, and it's a big mixed bag. there are some benefits to actually the switch over to more telehealth-based options. And it's clear that this is going to be, here with us in the future. For many people with multiple chronic conditions, it can be hard for them to get to see the doctor, either because they have to take off time from work, or maybe if they're old and disabled, actually getting out of the house and going to the doctor's office is a pretty big effort. And so having access where people can contact their clinicians by phone or by video actually eases barriers to access. But on the flip side, there is something really important about being there in person. You can do more. You can create a more important or closer relationship with the patient often, and also provide ancillary services, for example, lab tests or x-rays, or have them see the pharmacist who happens to be right next to you in a multi-specialty clinic. And those things are really irreplaceable in a video context. And so everyone is trying this out and kind of fumbling their way through it. And as we move forward, what's going to be really critical is coming up with ways that we make the best use of telehealth when it works, but also not pretending it can be a substitute for everything. In COVID, we have seen a lot of people delaying care or not coming in for care in a way that they should be, where their uncontrolled chronic medical conditions actually pose a much more greater threat to their health than their risk of getting COVID by going into the doctor's office or the hospital.
Yeah, we've been hearing about that quite a lot, where people are coming into the hospital at a much more advanced stage with their non-COVID related illnesses. Dr. Boyd, can you tell us how it's going at Hopkins? To what extent are you guys implementing these telehealth and other approaches to try to handle these patients with multiple chronic conditions? And do you really think that that is going to be an established part of the approach going forward?
Yeah, I would definitely echo what Dr. Steinman said. I think we're trying out a lot of the same approaches, trying to use telehealth when it really is a good adjunct and delivering the need someone has, but at the same time recognizing that there are still a lot of things where we need to see someone in person for all the reasons Dr. Steinman mentioned. I do think it's going to continue to be with us, and so I think we already are learning, and I think there's more to learn, and we need to be studying it, like how do we best use it to serve the needs with people with multiple chronic conditions. And I do think a really key thing is that that echoes back to a couple of your earlier questions is that I absolutely think primary care plays like a major role in coordinating and preparing for care of this population, and certainly geriatricians, which I am, and I do primary care in Baltimore, do as well. But I actually think it's really important that the whole healthcare workforce realize that many of the patients they are seeing have multiple chronic conditions, and so that and that even if they are the specialist in one of the diseases, that they really need to be thinking about how that fits into everything someone needs to do or is being asked to do, and like the role that the disease or condition that they're expert in plays in like the whole person, that we all have to be prepared for these patients. And so I think as we think about the role of telehealth and moving forward, trying to provide the best care of the populations, I do think we want to think about how the whole healthcare system can make the most of these tools, but then be maximizing the benefits of being in person when that is bringing what the person needs.
Dr. Bierman, can you talk to us about some of these tools that ARC is, well, not tools that you're rolling out, but some of the surveys and the work that you're doing in terms of determining which approaches are the most effective and making sure that they get out to everyone, as you alluded to earlier?
Yeah, so first I'm going to mention an interesting grant that we're funding in Kaiser Permanente, where they're actually developing algorithms to identify, those people with multiple chronic conditions at highest risk, and then link it to a database of community services to also address the social determinants of health and social risk, and provide that information to the healthcare team in terms of being proactive, and developing it in a way that could be shared and, across the health system at a later date. So I think using technology to really identify people who have increased needs and to better manage their care and get them the services that they can, I think will make a big difference. We're also working at ARC. We have a partnership with NIH to develop an interoperable electronic care plan. So basically think about an app that the patient can use, all of the patient's doctors can use, as Dr. Boyd was saying, the specialist, the primary care physician, and put in all the information about diagnoses, medications, plans, choices, so that people can really be informed and coordinate and integrate care. And I think, using as technology develops, we'll have better capacity to do these kind of things. And then finally, a big focus of ARC is the integration of behavioral health in primary care. And to think about if you have depression or another mental illness or substance abuse, and then also have things like diabetes, hypertension, cardiovascular disease, unless you get the right care for all of your conditions, your outcomes are going to be worse. And then the ways of aligning behavioral health in primary care is really important for people with multiple chronic conditions as well.
So let's switch a little bit, talking about some of those things that you pointed out, that there are many different areas of intervention that could happen. But I think that with a lot of these patients, especially who have multiple chronic conditions that are impacting the quality of their life, in many cases they have caregivers, spouses or family members, perhaps neighbors or friends, who are kind of bearing a lot of this burden. So Dr. Steinman, maybe you can talk a little bit about that. To what extent is this situation you're trying to empower the patient, but also making sure that they are getting the appropriate care when perhaps they're not able to mastermind all of their own care if they don't have a really great primary care setup? So the question is, Dr. Steinman, to what extent are caregivers involved in this process?
Caregivers are absolutely essential, regardless of whether or not you have a well-functioning or an ill-functioning primary care system. People who have multiple chronic complex needs that might be compounded by cognitive impairment or functional impairment or other difficulties with kind of taking care of their day-to-day tasks, having caregivers involved is just beyond critical. And if you would imagine for a moment, if all the informal caregivers, spouses, children, friends were to suddenly drop out of the picture, this entire country would fall apart. And so these people are doing heroic work that is typically uncompensated. And we have the supplemental system where there are compensated caregivers, for example, in-home support services or private pay services that can also provide critical, but they're typically not enough. So recognizing the value of caregivers is critical because it helps us focus on what's most important. And supporting caregivers, allowing them to do what they do best and giving them the resources that are going to help them take care of the patients is often the single most important thing, or one of the most important things we can do, because, as a physician, I might see someone in my office for 20 or 30 minutes once every few months. That caregiver is seeing that person every single day or every single week. And they're the person with eyes on. They're the person who's actually going to make the difference in terms of that person's health. And to the extent to which we can support those people, that'll be, is essential and will continue to be essential. And we don't always do a great job with it.
Another area where there is an awful lot of touch on these patients is their insurance providers, because those are the people who are seeing all the bills, so they do kind of know what services these patients are getting. And I know that a lot of them have set up things like, nurse call lines and individual patient support services to help kind of coordinate their care. Dr. Boyd, are you familiar with that process, and do you have any kind of insight or thought on whether or not that's helpful to physicians like yourself, somebody, on the back end of it trying to help coordinate, or does that, get a little bit more in the way, kind of confusing things?
It's a great question, and I think it's honestly one we still have a lot to learn about. Actually, sometimes patients will end up with more than one of those case management or other support systems operating in the background, and so and so how that all interplays and how does it end up actually being a net benefit is something that I think we do really need to think about. I think that there's actually a lot of literature out there about this, but some of the things that I think are really key about programs like that work well is when they are actually integrated with the care team that is really providing the primary care. So the more that the connections are really made to the primary care clinician in the office, to the specialist, and so that that those are the people in their relationship with the patient and their family that are really driving. I think that's where there's the most value, and I think we really have to make sure that we get the incentives right, that the incentives that are driven by our healthcare system and the insurers are working to make sure that providers really are working together, whether one of those people is actually working for the insurer or whether you're talking about, a primary care physician in the home healthcare agency or a specialist who's in a different health system from the primary care physician. I think one of the fundamental things that insurers can help us do is to make sure that the incentives are driving us towards working together.
So let's talk just for a moment about the idea that we do have these tools, Dr. Bierman, that you were talking about, but what's happening with the numbers? Are we seeing a lot more of these patients with multiple chronic conditions, or are things getting better in the U.S.?
It's getting worse. I call it a syndemic, which means multiple epidemics happening at the same time for all of these chronic diseases for similar reasons. But because of all of the, lifestyle issues, access to care, health disparities, the prevalence of multiple chronic conditions is growing. And that's why we need to do prevention as well as management. And we see, basically I see three groups of people. People of multiple risk factors who we could intervene early before they get the chronic conditions. There's people that Dr. Steinman were talking about who might have a few well-controlled chronic conditions who are doing fine now, but might be at risk in the future. So we want to make sure we optimize their care so they don't develop into complex patients. And those people who are already complex, there's a lot we can do to improve their care and improve their outcomes, reduce duplication of services, or even adverse events that happen because people are not communicating and working cross purposes. So I think it's great that you're highlighting this. I mentioned COVID before. And what we've learned is that people with multiple chronic conditions are at increased risk for COVID, increased risk for bad outcomes, getting admitted to the hospital, or mortality when they get it. So I think there's some urgency for really investing in the research and the care delivery interventions to improve care for this, growing population.
Well, thank you so much to all of you for participating in this panel. That is absolutely a great place for us to stop. Basically, we have the drawback that we have increased numbers here, but also some potential tools and benefits to get a better handle on this going forward. So I guess we'll wrap it up. Wish we could talk longer, but I'm going to hand it over to my colleague, Drew Armstrong. Drew?
Thanks, Michelle. Let's turn now to a discussion about innovative approaches to polychronic care. Welcome our panel, Dr. David Kent, Director of the Tufts University Clinical and Translational Science Institute, Dr. Rozalina McCoy, Associate Professor of Medicine at the Mayo Clinic of Community Internal Medicine and the Robert D. and Patricia E. Kern Center for the Science of Healthcare, and last, Dr. Omar Baker, Executive Vice President, Strategic Initiatives and Innovation, Optum Health, and the Chief Medical Officer of its Health Services Division. A reminder that Optum is our sponsor today. So thank you so much for all three of you for being here today. I want to start out with something of a background question while we're talking about polychronic conditions, because I think it's really important for people to understand what it is that makes possible some of the things that we're going to discuss today. And that's data specifically, very, very rich, organized data on patients and care. So, healthcare has this reputation for being a little bit stuck in the past. And Dr. Kent, I want to go to you first, and maybe you can kind of help us understand as a groundwork for some of what we're going to talk about today. What has really changed in the last decade that has made some of the analysis that we're going to talk about possible?
Yeah, well, actually, I'd like to go back more than a decade because I've been trying to do this work for maybe 2 decades. And I've noticed, an enormous change over the last several years. And perhaps the seminal event was actually the crash of the housing and the stock market in 2008. That might seem like a weird thing to say, but that led to the American Recovery and Reinvestment Act. And within that act, there was about $30 billion of incentives for the meaningful use of electronic health records. And we went from a period of time pre-2008, where we had maybe 10 or 15% of acute care hospitals that had electronic medical records, to, post-2010, where it shot up to 90% of acute care hospitals, and now it's somewhere around 96%. So we have the digitization of all these electronic health records, which used to be in handwritten notes. And now that we have the digitization, which is just a basic capture of the information, the question is, can we make that useful to us as researchers? And that still takes a couple of steps. We have to connect data from many, many different sources. That means connecting medical records data with billing data, and connecting that with pharmacy data, and connecting that with lab data, and then connecting one hospital to another, and then connecting patients longitudinally from their outpatient clinic to their inpatient clinic. And then that'll set up an environment for a learning healthcare system. And a learning healthcare system means we can actually glean, novel scientific insights, useful scientific insights, which can then be fed back through the same system, through the system of the electronic health care system, to actually influence care and decision-making. And that is really largely in place now. We haven't quite yet seen the revolution in care and decision-making that promises, but I think over the coming decade, that's when we'll start to see some big changes.
Just 1 second, because obviously you guys sit in a really interesting place, having an integrated system over there with doctors and a lot of data oversight. But I first actually want to go to Dr. McCoy and hear from her. She has perspectives here both as a researcher and a clinician, and maybe she can also add a little bit to what Dr. Kent was saying about kind of how this data landscape has transformed when it comes to being able to analyze and look at patients, but also to care for them.
Yeah, absolutely. I think, from the perspective of a millennial doctor, I think we definitely grew up with technology and having a lot more digital information for our patients available. But like Dr. Kent said, I think it's a very recent change, even as close back as my training in my medical school only had paper charts for most patients outside of the intensive care unit. So it really has been kind of a rapid transformation from first being able to see information electronically coming in from multiple sources, for me to see that no matter where I was, so that I could see patient information, whether I'm at the hospital or at the home, without having to go to their bedside and track down charts. It then transformed to me being able to put in electronic orders so that I could care for patients even when I'm not right next to them. And ultimately, to being able to put orders and communicate with places outside of my hospital, such as outside pharmacies, and really have that back and forth communication about our patients. And clinically, that has been really transformative, because now I can see what happens to my patients when they are outside of my office, whenever they go to the hospital, when they see even a different clinician because of the interoperability that was made possible by meaningful use. So having more complete information about my patients
helps me make more informed and ultimately safer and better decisions for my patients. And I think as we go forward and electronic health records develop the capability of really incorporating and synergizing data from a wide variety of data streams, that decision making will be even more patient-centered and even better. And I'm talking about not only notes and records from outside hospitals, but information from patients' wearable devices, whether it is their continuous glucose monitor or insulin pump, or any other sensor they may have, like an Apple Watch getting their EKG readings. So I think as we develop the capability, the ability to care for patients and make more informed decisions are going to get better. And I think that also helps research, because healthcare innovation happens using data that we have available. And imperfect data leads to imperfect clinical decisions, but also imperfect research information and research knowledge. So the more accurate and complete the information we have about our patients, the better the research and the better the clinical care. And for the polychronic population, I think this is extremely important. Just because of the complexity of their health condition and health needs, the completeness of information is going to be critical.
Dr. Baker, I want to turn to you real quickly. You guys over at Optum obviously have a whole lot of doctors and a whole lot of clinics, as well as a whole lot of claims data. Maybe you can talk to me a little bit about kind of how your information environment has changed over the time frame that Dr. Kent has been talking about. And then I'm going to use this to kind of pivot into the pandemic as a follow-up question and what it's meant for some of these more complex patients. So, Dr. Baker.
Well, sure, and thank you for having me. And if I can just layer on to some of the stellar comments made by both Dr. McCoy and Dr. Kent. Data is essentially information, and I fully agree with the panelists on the importance of the HITECH Act and meaningful use, which allowed for comprehensive data aggregation. The challenge, wherein lies the opportunity, was aggregating that data, but then converting that and analyzing that data where it can be actionable information at the point of care. Like you mentioned, at Optum Health, essentially all the decisions we make are to empower, enable, and guide those delivering care so that the patients receiving the care get optimal care. And to us, value is essentially an equation, at the risk of simplifying it. How can we achieve the best medical outcome at the lowest possible cost of care? And obviously, patient and provider experience are a part of that equation, with the quadruple aim being our North Star. But data is extremely important, which informs our clinical, operational, and strategic decisions. Besides data, it's also having aligned incentives amongst all the stakeholders. So, at Optum Care, we have north of 3 million patients in risk contracts, and 1.2 of those are seniors, which a large portion have multiple chronic conditions, because as we know, nearly 1/3 of Americans have 3 or more chronic conditions. So, we manage 1.2 million Americans in full delegated global risk contracts. So now the incentives are fully aligned for us to deliver the best possible care, close chronic care gaps, and ensure we are not only addressing the disease, but addressing the patient holistically with all the resources we have, not in a fragmented system, but kind of in a continuum that's properly and effectively stitched together, with the PCP, the primary care physician, and the patient at the epicenter of that system.
Here while we talk about this, because I think there's been this kind of, we talked a little bit about the changes in data over the last several years, but obviously we all went into this pandemic environment. And Dr. Baker, maybe you can talk a little bit about how some of this stuff was revealed in terms of how you all were operating when COVID-19 happened, and obviously that forced some of this stuff to the fore in terms of both these patients who, patients who have multiple chronic conditions, who are obviously highly vulnerable to COVID-19 illnesses, but then also, how that impacted how you guys were operating across the system.
As you mentioned, we have nearly 70,000 employed, affiliated, and contracted physicians across 43 states. So there was an enormous responsibility to effectively and precisely target our most vulnerable patients and members across this country during a time of a lot of uncertainty. But, we were steadfast on three pillars. Number one, continue to follow the science and be relentless about evidence-based medicine. Number two, do whatever it takes to protect our workforce. And number three, harness the data so that we can scale decisions across the country, across hotspots, and apply those lessons learned. And some examples were, around PPE. We needed to give our front lines the physical armor they needed. So we created algorithms that would appropriately and effectively predict burn rates, which informed where we needed to shift PPE because we could not have any disruptions in our clinical operations across the country. Another example that was critically important was we would monitor ER utilization data, inpatient data, and also with our partners at Optum Rx, they had access to nearly 13 million commercially insured members, and we would trend pharmaceutical prescription data, and that would inform us and allow us to more precisely target our senior members. Because what we did not want was, while we were entirely focused on the pandemic, we did not take our eye off the ball on those that had chronic diseases, and we had to do whatever it took to get to our vulnerable patients. And since the Emergency Declaration Act in mid-March, we've conducted north of 1 million virtual visits. The key there was using technologies and platforms, but our own PCPs that the patients were familiar with, and really listening to our front lines was crucial. That sparked innovation. An example of that quickly is a partnership between Optum Care and United Health Group's R&D division in collaboration with the Gates Foundation, which allowed for self-swabbing, for patients to swab themselves for COVID. This protected our healthcare workforce. This minimized burn rates around PPE. And after we published the data in the New England Journal of Medicine, it actually changed FDA guidance around self-swab. So this had an impact well beyond Optum and UHG, which we're really proud of.
Doctors Kent and McCoy, I'm wondering, how much of what's going on in this pandemic has allowed you guys to put into, either learning or practice some of what I'm sure you've already been working on, how you manage these patients, either doing so more virtually, figuring out how often you reach out and are interacting with patients about kind of complex conditions or managing one condition after another, or if there are particular insights that have been gained with these patients by looking at some of the early data sets. And Dr. McCoy, why don't we start off with you, though I'm sure you both want to chime in, and by all means, feel free to jump in wherever you like here.
Yeah, this really has been a rapid time of change, both learning and growth and opportunity. And it's been great having so much, just open discussion nationally about what everyone is doing and being able to learn from each other. In our clinical practice, I think a lot changed, a lot of it for the better in terms of resources and technology use to better serve our patients. So I'm a primary care physician, and I can share with you just the ways that it affected my every day that I go into the clinic. We now have a fair number of our appointments conducted by either a video or even by phone, which is really important for our older patients who may not have access to technology, or our patients who live in rural areas without strong broadband connectivity. So being able to deliver care to patients who are homebound, whether it is due to safety concerns for COVID, or because they may be in quarantine themselves, or because they are frail and elderly and are homebound as well. So we've been able to reach many of our patients and deliver really high quality care. We've surveyed our patients and our clinicians to learn about that experience, and it's generally been very well received. because it's bringing care to the patient when, where, and how they need it. At the same time, we've been able to develop kind of innovative approaches to care, specifically in the context of COVID. So for example, our remote patient monitoring system for patients who have COVID-19 has allowed them to remain at their home under very close monitoring and supervision by our clinical staff, but without having to go into the hospital. So patients receive a box in the mail with a welcome kit for the remote patient monitoring. Comes with a tablet that is cellular enabled, so they don't even need Wi-Fi, which has been great for our rural patients. A scale, a pulse oximeter, a way to check their blood pressure, heart rate, and all of that feeds directly to the healthcare team, who also is able to send them questions. So it becomes this interactive, sort of both live and asynchronous communication to identify deterioration in health, help troubleshoot problems, and keep patients safe at home. We've had other programs that brought care, again, to the patient's home, like engaging more with our community paramedics, who have been the only team to go into the patient's home despite COVID, even to see COVID-infected patients. Again, making sure that no matter the circumstance and no matter the need, all of our patients' needs continue to be met, because we really wanted to avoid the situation when patients forgo care, whether it is because that care is not accessible or because they are scared or they have no way of getting there. Because forgoing care for chronic disease will lead to so many problems, both now and in the future. So we really wanted to make sure we anticipate and meet those needs.
Dr. Kent, I do want to come to you, but Dr. Baker, I'm wondering how much of that type of remote monitoring have you all been doing on your side as well? This is something I've heard a lot about from folks across the country, actually, about the question of how do you actually keep people who don't need to be in the hospital or in the urgent care out of there, both for a healthcare utilization burden standpoint and just for their own safety.
Yeah, and we've been doing this before the pandemic. What the pandemic allowed us to do, and was to accelerate this and augment this in a more customizable and scalable way, where it was more nationally relevant. Some of the products and capabilities across Optum Health, besides the Optum Care clinics, are our house calls business, which does hundreds of thousands of at-home visits a month. And this was, redeployed and repurposed during COVID in a really effective way. But to your question around technology and how we combined that during the pandemic, we used a remote patient monitoring platform called Vivify, which is one of our assets. And an example was in our Seattle market. We combined our virtual capabilities with the PCP of that patient with a 24/7 nurse line under our population health services division that was also connected to our remote patient monitoring to monitor duly eligible members, approximately 9,000 of our sickest members. And these historical point solutions were quickly brought together as a comprehensive solution to monitor our sickest and most vulnerable while they were at home.
Dr. Kent, I want to come to you real quickly, because I know you work with some. You've actually had access to some very large data sets, I believe. You mentioned out of New York and out of the Netherlands. Maybe you can tell us a little bit about what you've been about those sets and what you're looking at, and kind of. I think one of the questions I have for you is, when you're working with the access to the data that you've described, how do you begin to pull out kind of individual learnings as opposed to kind of broader population analysis? I mean, how does this say, hey, we've got 16,000 patients or 1 million patients? How do you tailor this down to the level of a patient for a clinician that they're going to be able to apply this stuff?
Yeah, well, I'm glad you asked me, because that's one of the areas of research I'm most interested in. Just to pull back a little bit, in addition to doing research, I also work as a hospitalist here at Tufts Medical Center in Boston. And, even in the short amount of time that we've been dealing with these viruses, we've seen some new treatments come online, and I anticipate we'll see some more new treatments. So we've had remdesivir and dexamethasone come online, and I anticipate there'll be some more. And as these treatments come online, and as we get better in supportive care of these patients, we're seeing our mortality rates drop quite a bit. We have funding here from the Patient-Centered Outcomes Research Institute to create some predictive models to help prognosticate with these hospitalized patients to support really patient-centered decision-making. Decisions about whether people want to be intubated, given what their risk is of having very long, potentially very long stays in the intensive care unit and a potentially high mortality rate. We've teamed up, as you said, with hospital systems in New York and the Netherlands to have over 16,000 hospitalized patients to help support this predictive modeling. And really having these very large patient populations is necessary if we want to individualize decision making, because the more variables that we think are important to include in prognostication, the more patients we need to make accurate estimations. So, having 16,000 hospitalized patients really permits us to make better estimations, make use of a broad array of data, including, demographics about the patients, comorbidities. Does the patient have diabetes, hypertension, and other comorbidities that might play into mortality, lab values, and so forth. Without this ability to routinely collect data during clinical care that can be repurposed for research that can then be fed back for clinical care, we wouldn't be able to do this. And I guess the other thing I want to make clear is that over time, as the mortality rate drops, we hope to have the ability to recalibrate these models to account for all these new therapies as they come on board, to make sure that our prognostication, keeps pace with the changes in clinical care.
I want to throw this open to all three of you. I mean, when we think about who has been most vulnerable during the course of this pandemic, elderly patients, people with underlying illnesses, are there particular insights you all have seen develop over the last few months or been part of yourselves that have kind of applied to how you deal with these patients and both how you protect them and then both if they get sick, how you treat them? And I'm happy to just kind of do round robin on this. Maybe Dr. McCoy, you can go first, and then we'll go to Dr. Baker and Dr. Kent.
Yeah, I think the most vulnerable populations really have been, the elderly, people who live in rural areas, and I think in a lot of the historically underserved populations, so racial and ethnic minorities, and in our particular population, people with limited English proficiency who may not have close ties with the healthcare community or may not speak the language. And I think we've really taken a step back and thought about what are the needs of those different communities. We worked with them directly to identify ways to reach them better. And to give you just a few examples, it includes setting up connectivity within every single nursing home in the Southeast Minnesota region, including all of our rural sites, so that our physicians sitting in Rochester would be able to remote into kind of a location in any of the nursing homes. And the iPad there on site would be equipped with peripherals in order to allow the physician to listen to individuals' lungs and heart, to speak with our nurses, speak with the patient, figure out what's wrong, and really care for the patient without having to go into the nursing home. And as we've seen, nursing homes have really been hard hit by COVID-19, and I think that has been very helpful for our populations. We've also partnered with community health workers, with community paramedics, and really worked to engage individual communities and try to best serve their needs.
So I think as I turn to Doctors Baker and Kent, I think I'm going to use an audience question from Leo in Maryland about research sharing, and I actually want to broaden his question a little bit as we start to get to the first of two audience questions. Within the context of the pandemic, I'm wondering what you all think are kind of the biggest data or data sharing barriers that we have seen, or places where you think more can be done. I mean, what are the pieces of information or the data sets or the type of information you all want to have access to in order to better protect or better treat or analyze what's going on, especially in some of these at-risk populations?
So, I think what this revealed to us is the importance, not all data is treated equally. So it's having the accurate, validated, timely data that's actually going to have an impact on care delivery. That's what became most important for our front lines. So, I don't think it was a question of what we need today. It was a deeper understanding of kind of integrating historical, operational, and technological platforms, combining clinical and claims data to tell the story, because, providers and clinicians, did not have the time or bandwidth to sift through data to interpret it. So we needed to do everything we could, all of our clinicians behind the scenes, all of our data scientists, all of our actuaries, to arm our clinicians with the data they needed to best treat those in the exam room. So, what it allowed us to do was to deepen our partnerships, not only within United Health Group, which was, quite powerful, between the clinical muscle and the intellectual expertise, but it was really partnerships externally between departments of health across states, partnerships with the CDC, and partnerships with academic health systems and hospital partners. It allowed us to get where we needed and get that information a lot quicker to those that needed it most.
Great. Dr. Kent, to you.
Yeah, so I guess, this doesn't have necessarily to do with COVID specifically, except the one thing I want to say regarding COVID is that, we've also seen some of the limits about how fast we can make data available, in that we've had some very high profile retractions of scientific information. And I think this is the type of environment where you can, anticipate, because of the speed of research, more mistakes, more errors than we would have under more normal circumstances. The other point that I wanted to, the other large change that has happened over the last decade, besides the linking of the electronic health records, is really a culture of open science. We, here in my group, we do a lot of secondary analysis of clinical trials, and there has been much more broad access to clinical trials. There are a number of platforms that make clinical trials routinely available. So we have access to hundreds and even thousands of old clinical trials, which are important to us because only in clinical trials do you have randomization. And if you're interested in really looking at the cause effect of new treatments, even in individual patients, you want to do pooling of clinical trials. You could only do that in an environment where researchers, investigators, industry companies are willing to share their data. We're not fully there yet, but the change over the last decade has been really tremendous.
I'm going to do one last audience question, and I'll throw this up to whoever wants to raise their hand and answer it. This is a question from one of our viewers in Texas who asks, what do you see the role of AI being in using some of this data, either in interactions with patients or how you all are analyzing it from a research perspective? Does anybody want to field that? I'm willing to take one from anyone here.
Talk a little bit about that. I think we generally, in terms of gleaning insights, doing regular descriptive and inferential statistics, we have a lot of classical statistical tools that we've been using for decades that work fairly well. In terms of making predictions, which is an area that I work in, I think a lot of our classical statistical tools work fairly well, and the incremental gain with some of the newer models, sometimes called machine learning, might not be that revolutionary. I think there are some specific areas. This is, again, my bias, and other people will differ from this interpretation. Image analysis, natural language processing to take unstructured data and make it into structured data. There are some areas where these newer tools are totally outclass our classical statistical tools. But, I tend not to make a big division between artificial intelligence, machine learning, and classical statistics. These are all tools that we're using really to get insights and learn from the data and create a learning health system.
So we are a little bit over time, so I'm going to wrap it up there. This has been wonderfully insightful, and thank all of you very much for taking time out of your day. Thank you for joining the Future of Healthcare, Caring for Polychronic Populations virtual briefing. We hope you enjoyed these discussions, and we welcome your feedback. Please complete the brief exit survey that will appear on your screen at the end. Thanks again also to our speakers. We'd also like to thank Optum for making today's event possible. And if you'd like more information from Optum on polychronic care, please go to the handout tab on your screen. And for ongoing COVID-19 coverage and other stories, please go to Bloomberg.com and follow Bloomberg on Twitter at Bloomberg Live and @Business. Thank you so much for being with us today.